Can you see the screen?
Yep, I can. Yep, we're good.
All right.
All right, let's roll.
Should I start?
Yes.
Hi, everyone. This is Dr. Ruth He. I'm a medical oncologist working at the Georgetown University Hospital. My main focus is on GI malignancies. I do collaborate with IR on a lot of hepatocellular carcinoma cases. So today, I think I want to share with you is some basics of tumor immunology, and also the rapid development of a lot of immunotherapy agent against cancer. And you know, tumor immunology, people can talk about for hours and hours. I'm going to just really show some basics. And so I have total 8 slides. And before I go into the detail, first I want to set the stage. So, you know, we all have intact immunity. So when we're infected with bacteria or viruses, and we're able to detect the antigen that's not the same as what we have, and we can mount an immune response and eradicate the bacteria and viruses that we're infected with. Cancer, you all know, cancer carries a lot of mutations, and if you remember, the pathology class cancer cells do look different from us. So why they are able to survive in our body with immunity. And so indeed, when cancer initially is formed, it remains dormant in our body for a long time until it overcomes the immune surveillance. So usually there are 2 mechanisms how cancer escape from the immune surveillance and immune attack. The 2 main mechanisms, one is it makes it so it lost immunogenic antigen by decrease the production of the antigen, or screen out those and make the tumor antigen not so immunogenic. So that's one mechanism. Second mechanism is to make the environment in the tumor, around tumor, very immunosuppressive. So yeah, suppress the normal anti-tumor immune response by increase a lot of immune inhibitory suppressor molecules, cytokines, or suppress the anti-tumor T cells and NK cells, the active fighters, and in the tumor microenvironment. Those are the 2 main mechanisms how tumors survive through our immunity. So in order to overcome this tumor immune evasion, and scientists and physician scientists developing many ways try to overcome it. So first, if there's a poor, so if now you look at this busy slide, so on the top it says adequate cancer antigen presentation. On the right is poor antigen presentation. Let's first talk about if the tumor has if there's a poor cancer antigen presentation. So in order for the immune cells to attack the cancer, so the immune cells has to, so the antigen of the cancer has to be presented on MHC type 2, if you remember back in the old days in medical school. And then that gets presented to immune cells, and B lymphocytes will generate antibody, and T lymphocytes will activate T effector cells and go attack these cells that present in this antigen. So if there's poor antigen presentation, so you can see there are many ways, such as tumor vaccine. So basically identify a tumor antigen, specific tumor antigen that's very immunogenic, or you attach a tumor antigen with a immunogenic molecule and try to trick the immune system to fight that tumor antigen. And the other is oncolytic viruses, such as T-VEC has been FDA approved for treatment of melanoma. And basically, you infect the oncolytic virus, you infect the cancer cells with oncolytic virus, and then it will burst this, it will cause the cells to lyse, and then release tumor antigen, and hopefully induce an immune response. So you use oncolytic virus to kill the cancer cells, and hopefully that will induce a cascade of immune response, and then result into a treatment effect. And the other thing is engineered T cells. So basically, you engineer the T cell receptor that and then that will recognize tumor antigen and part of the molecule that present the antigen. So in the whole category of treatments are just trying to make the tumor release some antigen that's immunogenic. And I think you all are physician in training, and you can see some of the treatment you guys do may help with releasing the antigen, such as ablation or radiotherapy that may cause inflammation and release tumor antigen, and then hopefully will induce an immune response. The other thing is cytokine. So cytokine, there are molecules generated by immune cells and other type of stromal cells. They are messengers. Basically, they can send a message far away and this, far distance from this site, and then try to attract immune cells to come in. So the most famous cytokine is interleukin-2 that's approved for renal cell carcinoma and melanoma. But it's quite toxic, and now there are second, third generation of cytokines are well tolerated and also under development for that purpose. Basically, try to induce an immune response against tumor. So if the tumor has adequate cancer antigen presentation, so how can we overcome the immune invasion? So now you're going to see the next slide, and basically I'm bloating up that centerpiece of the first slide. So on the top is T cell inactivation, and on the bottom are T cell activation. So the tumor, on the lymphocytes, there are many surface molecules. Some will, if the ligand binds to the surface molecule, it will activate the immune response by cause a lot of T cell proliferation and make the T cell geared up to fight, and with all this enzymatic activity inside the cells to fight the tumor or fight bacteria or fight whatever it's going to fight. And there's also molecules on the cell surface that will put out the fire, basically. So this is a protective mechanism, a normal mechanism in our body. For example, if you're infected with bacterial pneumococcus and you have a pneumonia, and when the T cells will activate it, try to put in a fighting mode to fight this bacteria, at the same time, the surface molecule called PD-L1 will be overexpressed. What it does is it will try to limit how big a fire you're going to set to fight this bacterial infection, because it's a very potent, effective process in our body when we turn on our immune system. So then the cells express what we call immune checkpoint, and because it will suppress the immune response and make sure the immune response will not hurt ourselves. And so cancer actually use this mechanism to fight, to protect them from immune attack. So the molecules, if you can see, the most famous two molecules that now we have quite many therapeutic agents target this molecule is PD-1, PD-L1, CTLA-4. Basically, the tumor induce the molecule and to sort of put out the fire of immune attack. Of course, you can also see there are many other molecules, TIGIT, TIM3, and LAG3. All those are molecules, also immune checkpoint molecules. So currently, there are a lot of very exciting drugs are being developed to target those. What it happens is when we develop an antibody and binds to those inhibitory molecules, that will separate the interaction between that molecule to the ligand, which are on the immune cells to activate the immune cells. And you can also see tumor cells use many of those immune checkpoints to fend off the immune attack. So if we currently have drugs to those two CTLA-4 and PD-1, and of course, if the tumor uses a different immune checkpoint, and then those drugs won't work. That explains why only a portion of patients will respond to a specific treatment. And now the other group of molecule are Tcell activation molecules, such as CD40, CD28, OX40, 41BB. Currently, there are a lot of drugs are being developed to target those molecules to activate the molecule and to activate immunity to fight the cancer. So now I'm going to show you a table, and quite a busy table. I put large blue arrow and a circle because those are FDA-approved drug. And discovery of the immune checkpoints has led to development of a lot of new drugs. And that totally changed the landscape of treatment across disease type. And so we are able to put some patients in remission because if we are able to inhibit their immune checkpoint, and then they can, then sometimes they even have a complete disappearance of the tumor. The most famous celebrity that has had cancer put in remission is President Jimmy Carter, who 5-6 years ago had metastatic melanoma to brain and liver. And without this kind of therapy, his estimated survival back then was 3 months. And then now his melanoma is still in remission. So this treatment can be very powerful if the cancer use that immune checkpoint to fight against this person's own immunity. And all the other drugs in this table are still being developed. So you're going to see a lot of new drugs coming through, and then we may be able to treat a lot of cancers more effectively compared to the chemotherapy. So I have, I'm going to show you how just the landscape change in HCC. So 2007, we had the first drug FDA approved, sorafenib. 10 years, we did a lot of study. They were all negative. 2017 to now, we have 8 FDA approved treatments. We really, I think we're proud to say we've changed 2 things. We really changed the response rate from single digit to 30-40%, and means those 30-40% of patients won't have significant tumor shrinkage. And then the other thing I think we're proud to say is we have made those patients with advanced liver cancer live much longer compared to 10 years ago. And so I want to make a point here is this is Nivolumab, which is anti-PD-1 therapy, and we participate in this phase 1 study, and the drug by itself works in 15 to 20% of patients. So this is RECIST 1.1 criteria. So basically 30% or more tumor shrinkage. And if you look at this figure in the panel, you can see patients, so one is sorafenib naive, the other is sorafenib refractory. And you can see there's about 20% of patients will have very long-term disease control. The survival curve flattened. So you can see those patients can live a long, long time without progression. And when this study was tested in our randomized phase 3 study, however, it did not beat sorafenib, which has a median overall survival of about a year. The reason is that this only provides significant benefit to only 15 to 20% of patients. A lot of patients don't respond. So when you look at the survival, median survival, this 15–20% of patients is not really able to move the median survival point. And so in July, actually, this drug was withdrawn by BMS because of the FDA, after the FDA ODAC meeting that recommend not continue approval of this drug. But the other progress we've made is we're doing combination now, immune therapy combination. So this combination is bevacizumab plus atezolizumab, and it led to the FDA approval in 2020. We're able to increase the response rate from 30 to 40%. And patients, if you look at this blue curve here, and about 30%, 20 to 30% of patients, the curve again flattened. You see the tail end. Those patients are unlikely to progress. A lot of them live for a long, long time because we have reset the immune checkpoint. So their own immunity are fighting against the tumor. So what's in the future? I'm going to leave some time to talk about IR cases. So the future direction is we're scientists and physicians and in medical oncology, we're trying to increase the response rate, basically from first from 20% to 40%. We hope to increase that further to make sure that more patients will benefit this kind of approach. And second, and we want to identify a biomarker to identify responders. So we'll spare patients who will not respond to this treatment and from this expensive treatment. And I think that's sort of a summary. I will stay on if later you have some questions. I think I'm going to hand over the podium.
Yes, thank you so much, Dr. He. And I think at this point we would invite Dr. Toskich to join us, and we will start sharing Dr. Toskich's slides, and after that, Dr. Toskich will start giving his talk.
I do not know. I guess I have been, okay, great. So I have stopped sharing.
Right, Dr. He.
Do you want me to share Dr. Toski's slide?
If you have time and if that would be possible for you, Dr. He, then that would be great.
So I'm downloading his slides right now, and there are 2 slide deck. And well, is there a chat box he can send me messages and to tell me and which slide deck he wants to show?
Sure. Can you guys hear me?
Yes, Dr. Toskich, can you?
Dr. He, can you hear me?
Yes, I can hear you.
Okay.
Are you able to see the slides?
Yep. If you just want to go in slideshow mode, I want to thank everyone for sort of tolerating me speaking through a phone through Zoom, through the webinar software, but we had some last minute technical issues. So with that, let's basically roll into the purpose of this talk, which is to kind of provide an initial survey for people who are interested in the interaction between immuno-oncology and local therapy. Next slide. These are my disclosures. Next slide. So we ultimately need new ideas and people that are going to think laterally. And believe it or not, it really starts with pretty much the folks who are attending this lecture. And you know, I think that's an important aspect to why these conversations are important to have, even though we're talking about some things that are you know, pretty complicated and still uncertain. So definitely we will want your input once you guys you know, come to that point in your careers. Next slide. And yes, we're going to kind of go through this as a conceptual approach to this. So don't worry too much about memorizing molecules at the expense of sort of your mental playfulness. Next slide. So I pulled out my old immunology book And that's a picture of me when I was actually studying out of it. And next slide. I looked in there and I wanted to see sort of what we knew back then. And there was a small little blip on CTLA-4. And when you discussed programmed cell death, it said, see something that was not exactly what we were talking about, and not apoptosis. The PD axis had been discovered at that time, but we didn't really know what to do with it. So, little did you know that sort of when you're studying these things, that later on, it's something that, I personally discuss with patients almost every time I'm in clinic. So it is interesting how these things do make full circle. Next slide. So everyone who's attending has likely at some point had some form of cancer. They just didn't recognize it, and your immune system took care of it. Next slide. And obviously, your immune system is the best weapon that we have to fight cancer. It's better than any scalpel or any thermal ablation probe or any systemic agent. It's just really complicated, equally like cancer is complicated. Next slide. And so we'll go through some of the basics of the immunology that's important with respect to local therapy. Obviously, Dr. Hay did a fantastic job going through more details. So we're going to skim through it. Next slide. So obviously, this process of immunoediting is important because there are things that pretty much only become detectable by the interventional radiologist at the level of escape. So if you look, elimination happens before we even know anything is happening. Equilibrium is usually equipoise and is pretty static. And then escape is typically when things become clinically evident. So biologically, we're already engaging things that have already figured things out a bit far down the road. Next slide. And the ultimate basics of it, which Dr. He covered, is that ultimately your cytotoxic lymphocytes will have to be in some way made alert to the presence of a malignant cell, and that there's this delicate balance between trying to obviously attack intruders and not generate autoimmune disease. But ultimately, cancer finds crafty ways to go immunologically cold, which is falling off the grid and being non-detectable. And even though you can have an enormous mass in someone's abdomen, from the immune system standpoint, it's blind. And that's where IRs and radiation oncologists and anyone who practices local therapy may have a role. Next slide. So yes, this is a picture of Daniel LaRusso from Karate Kid, and he's practicing the perfect balance between attacking invaders and autoimmunity. Next slide. So as it stands right now, most of the systemic immunotherapies that are present within the interventional oncologist's clinic are systemic agents that predominantly just remove the inhibition of stimulated CTLs. And very, very rarely do we see this as a standalone curative effect. Now, there are reports, and certainly every once in a while we see it, but most patients really don't respond in this way. Next slide. And so if you look at local therapy basics, which involves surgery, there's curative removal of all the antigens and the offending agent. There's ablation, which can be done with heat, cold, compression waves, either through HIFU or histotripsy, ethanol, super high dose ablative doses of radiation, lasers, irreversible electroporation. And there's palliation in the form of ischemia and cytotoxic agents and low-dose radiation. But all of these ultimately have some type of internal liability. There's ultimately a watershed of their therapeutic efficacy. And that's really where a lot of this interplay comes alive. If something is sitting on the surface of the sun, I don't care what biology it has, it doesn't survive. But it's that fall off in terms of efficacy that really where the battle sort of begins. Next slide. So the primary intent of local therapy is usually to eliminate visible small volume or oligometastatic disease. There's a nodule or there's a mass, and we tackle the mass, and we hope that it shows response and lack of progression. But the immunologic benefit is not something that we're used to looking at. And it involves, obviously, antigen presentation and modulating the immune system, making things become immunologically visible or hot again. And this, hopefully results in a activation of the immune system, which can be observed in the form of an out-of-scope or abscopal tumor effect. And again, abscopal effects are even rarer than the responses that we see that are very deep with standalone immunotherapies like checkpoint inhibitors. Next slide. So some involving concepts, and this is mostly in vitro. This is important to establish because these are rules that make a lot of sense on a petri dish, make a lot of sense with murine models, make some sense with retrospective studies, small observational pilot prospective studies in humans. But this is still absolute brand new territory where we welcome new investigator input and ideas in terms of how to actually get these, 2 fractals worth of permutations with cancer and immunology to become more predictable. But we'll cover some of those concepts broadly. Next slide. So first thing is, where is the tumor? Now this seems simple enough, but it's important. Next slide. When you look at a lesion, for example, this hepatic segment 4B lesion, that was, biopsy-proven HCC, someone can say, well, that's a small nodule, I can ablate it. But if you look at the way this patient ultimately progressed, there was bilobar vascular invasion extending to the main portal vein within 11 weeks. And so this is something that basically almost mimics a glioblastoma in the brain, or where you have tumor that's everywhere and mimicking cirrhosis. But no matter what therapy you do to that one nodule, you have a reconnaissance issue. You will never be able to treat it all because you weren't targeting it all to begin with. And this is a little bit more challenging than initially at face value, but it is a good concept to start off with. Next slide. So what is the tumor made of? Next slide. We classically rely on T stage, what size of the tumor, or, what is its AFP secretion. But really, tumor aggressivity is a full kaleidoscope of variations. And obviously, size is predictive in general of some tendency. But really, what we should be doing is tailoring applications of local therapy or any kind of oncologic intent to the phenotype of the tumor. So here's an example of a very early T-stage tumor in the fact that it's less than 2 centimeters, but already the AFP is 107, and it has a disrupted pseudocapsule in some areas of autonecrosis. Now, those are findings that classically predict poor biology, and true to the fact, if you look 50 days after the patient's previous normal chest CT, there are multiple lung metastases. So we're going to have to get smarter other than just size criteria in terms of what we do to engage tumors. For example, one would argue that adding some type of adjuvant to the immune system in this type of patient may actually be of benefit. Next slide. So how much needs to be treated? Next slide. So I think IRs are susceptible to this concept of lesion Photoshop, where you can see a little bright lesion there, and then I just want it to be erased. But the reality is, for example, there's been some great work at Memorial Sloan Kettering looking at the mutational status of colorectal mets. But what you're engaging in terms of visible disease needs to be a function of what you can tell is there and what you can predict is around it in its at-risk margin. And that's very important for good outcomes, particularly as we discuss some of the effects that thermal ablation may have that are not favorable for residual tumor that may be in the periphery. Next slide. So here's a nice graphic by Dr. Aaron Jerry's group, where they show kind of how many actionable therapies may be present, extending from the central necrotic zone of where a thermal ablation is performed to the peripheral transitional zone to the tumor and to the normal liver. And we're not going to go through these all at this point, but it at least shows you exactly how much along that interface between the therapeutic edge of your modality and the environment of the host as to how much that makes an impact in terms of where you have leverage to apply a therapy. The next slide. So what is used to treat tumor? This is a very common question that's asked by our fellows. Next slide. And it's interesting because in the beginning, when we looked at outcomes for different therapeutic modalities, for example, let's pick thermal ablation, a lot of times it was, they're fairly similar, or there's not a huge statistically significant difference. There's actually a nice prospective study that was done between microwave and radiofrequency for hepatocellular carcinoma that showed no significant difference. But when you look at how these interact with the immune system, they're actually quite vastly different. And so you can see that in this study here, this is an in vitro study that looked at irreversible electroporation, cryotherapy, and heat therapy. And you can see how much protein denaturation is accomplished by heat in the bottom right square. But if you look at how much protein release, overall, it looks like IRE wins. But if you look at native protein, in terms of ultimately what's the best representation of the initial cell, it looks like cryo wins. So again, these are some of those aspects of in vitro which we're trying to look at capturing in vivo and in clinical studies, but this is where there's a lot of work that's still needed. Next slide. And even if you've picked a modality, so this is a study that was done by Munit Ahmed's group and Nam Goldberg. They looked at, okay, well, if you just take microwave, instead of just saying microwave versus RFA, what about microwave that's done sort of a slow, like sous vide roast microwave, or very intense flash fry microwave where it's high wattage, immediately goes up to speed? And they found that the release of interleukin is actually most favorable where it's maintained in low levels when microwave is done very quickly at high temperatures, and they have seen interleukin be a stimulatory agent for distant growth of disease. That's a phenomenon that was discovered early on in some of the earlier studies with radiofrequency ablation, where a patient would undergo ablation and all of a sudden they would have a lot of out-of-field and off-site tumor growth. So it gets very complicated. You can imagine all the things that we've done thus far to try to predict the best way to practice, and it's not exactly easy. Next slide. So what else is local therapy doing? This is where we're going to talk about the downside. Next slide. This is where we've identified, again, mainly in vitro, but there are inflammatory factors generated by thermal ablation that can obviously modulate the immune system favorably, but there goes that balance again. Sometimes it does it in the opposite direction, and it depends on the outcomes, and that's what's becoming a little bit difficult to predict. And there's even some animal studies looking at inhibitors of some of the agents that are generated, like heat shock proteins and CMET, and trying to see if that reduces out-of-field growth, and it does. So again, it makes sense in vitro that sometimes you aggravate a tumor, and sometimes you aggravate the body into a type of immune response that is actually going to be stimulating for tumor. And you can see in the publication by Shi, there's actually sublethal damage of tumors negatively alters its biology. So if you engage a tumor partially just to kind of debulk or to do the best that you can, you may actually be doing a disservice from a biology standpoint, which we know is king. Biology is really what determines outcomes of patients almost more than anything else. There's even a nice study that looked at upregulation of lymphangiogenesis that leads to nodal progression in patients that had liver transplant who had suboptimal necrosis. So all these things are important because we have responsibilities as interventional oncologists to not just sort of tinker. We have to go in with a definitive oncologic intent based off of the best available data, and right now that would support sort of not partially treating tumors, at least certainly as a standalone. If you do it in the setting of immunotherapy, that's when things get even more complicated. Next slide. So what is the local immune environment? Next slide. So we know that when you have something simple like colon cancer on the face value, when you look at it in terms of its organ of origin, whether it's midgut or hindgut, it's actually a completely different beast. You have highly aggressive, highly immune revved up, very hot tumors that tend to originate from the cecum to the ascending of the transverse colon. And then you have more sort of cold tumors, but ones that tend to be sort of quiescent and tend to sort of have small metastases that can be treated with multiple focal therapies, and that in general tend to carry a better prognosis. Now, obviously, this is not 100% always the rule of the land, but there are trends that are pretty reproducible. And so not even is just colon cancer, but it's where did it even arise that matters. For example, a patient with a right-sided colon cancer is much more likely, because they have high microsatellite instability, to be a candidate for things like immune therapy. Next slide. Here's a patient that we treated that had an enormous celiac artery node metastasis from HCC. that responded completely. We don't commonly get PET. This was obtained at an outside hospital, but it's a nice demonstration of how you have a great immunologic response outside of the liver. But guess what? The liver has its own immunologic compartment, and it was allowing this primary tumor to escape, to continue evading the immune system. And I think that's important because if you think of all the antigens that your liver is exposed to throughout your entire life, it has to be that way. Otherwise, you wouldn't be able to obtain nutrition. So even you'll have micro immune compartments even within the same patient. Next slide. And this is sort of just a quick paper that identified that patients who have NASH cirrhosis may not respond that well to immunotherapy. And so now it's not only is it HCC, not only is the phenotype of HCC, not only is it within the liver that has its own microenvironment of immune system, it's also what caused the HCC. And if it was non-viral origin, hepatocellular carcinoma, we end up having some resistance immune therapy due to pre-existing T-cell exhaustion. Here, next slide. I lost my screen here. Let me see. I'm reconnecting to Zoom. I apologize. It timed out on me. Here we go. So how do we tie all this together with combination therapy? It's not easy, but here's an example of why we should. Next slide. So this is a patient with multifocal HCC who had multiple bland embolizations and a thermal ablation and preserved liver function, Child PUA. The patient eventually progressed on sorafenib and did not respond to 2 cycles of Nivolumab, which is an anti-PD-1 drug. Next slide. So this patient, we decided that we were going to maintain his immunotherapy and perform cryoablations to just 2 of the 8 lesions in hopes for an abscopal response. The patient was not a transplant candidate at the time due to high AFP. Next slide. And what we saw was that there was this large spike in AFP from 400 to over 1800 shortly after the initiation of immunotherapy. But literally the moment after the cryoablation, we had this precipitous drop. But that durability kicked in. Now, mind you, the immunotherapy was on board. The cryoablation only treated partially the disease, and yet you had response per imaging and per serologic tumor markers that lasted over 3 years. And this patient actually just got listed for transplant at our institution, having initially had an AFP of over 1800. And I think this is exactly why, next slide, we need to investigate this, because right now we have a very broad and very expensive and very onerous and very ultimately a bit of a letdown for patients who don't respond approach to it. And it makes it to where when you look at it from a population standpoint, that it may not be worth it if you look at just standard Kaplan-Meier curves. But for that patient, it was totally worth it. And I can tell you that there was nothing that we could have offered within IR as a standalone therapy with multifocal bilobar disease that would have had that kind of result. So 100%, we need to focus not only on just out-of-field effects, but in-field effects too, and we shouldn't stop trying, because these are some of the best results that we've seen with cancer therapy in the liver. Next slide. It's just a quick plug for a case series that we did that just showed that patients with vascular invasion could be treated in a neoadjuvant fashion and brought to either curative resection or transplant with complete pathologic necrosis, combining ablative radiation lobectomy and immune therapy in the form of checkpoint inhibitors. Next slide. So studying combination therapy is difficult. There's multiple agents now on board. That adds toxicity. There's complexity of obtaining tissue. If you try to biopsy the immune microenvironment of the tumor, good luck without doing a saturation biopsy and essentially almost doing a percutaneous resection. It is so variable. Assessing this in its interplay with the micro and macro environment is difficult. Even if you think things are supposed to work, T cells get exhausted or there's energy. How we deliver our therapeutic agents is very heterogeneous even amongst institutions, and these studies are extremely expensive. And when we look at things like registries, that's great. There's real world data with that, but it's often imprecise. So that's something else that's a big challenge right now, is that just studying this combination therapy is actually quite challenging. Next slide. So what has combination therapy shown so far? The data is heterogeneous, as can be expected. So the in vitro and animal studies have all been positive. Otherwise, you wouldn't be this psyched about it. If we look at what's been done in humans, it's predominantly retrospective and case reports. There's some observational and some phase 1, phase 2 studies. And certainly there's some response and survival benefit signal, but it doesn't really match what we would have 100% anticipated in vitro, which means that we're missing a piece of the puzzle. Hopefully, to elucidate this on a grand scale, there are multiple 500-plus randomized phase 3 studies that are going on right now, looking at predominantly TACE plus immune checkpoint inhibitors and VEGF access drugs. But there's also one for ablation, and there'll be some that are coming out for radioembolization as well. Next slide. And here's just a quick snapshot of some thermal ablation studies that have been combinations. You can see a lot of them are phase 1 or phase 2 observationals. Very heterogeneous types of tumors, so it's hard to say exactly because all these behave very different. You have some immunologically cold tumors like colorectal lung metastases, but then you have some hot ones like renal cell cancer. But if you can see in general, in terms of the impact, is that there is overall an upregulation of what we need to fight cancer from an immunologic standpoint as we can best measure it. And again, I think that's the predominant drive to continue looking into these studies. Next slide.
Okay, thank you.
Thank you.
And is Dr. He?
Yes.
Is she just getting 1 unit of blood?
Next slide.
Hello?
Hello?
Dr. He?
1 second. One
Okay.
second. Okay. Sorry.
No, you got to take care of patients first. Next slide. All right, perfect. We're good. All right, so is combination therapy safe? So right now, the reported prospective adverse event rate is in the low teens with single-agent immunotherapies. There's a lot of interest in adding multiple agents, which may add some toxicity. Right now, with doublet immunotherapy agents, there haven't been any new major safety signals. So it'll be interesting when those are added in conjunction with local therapy. We will find out. Next slide. And here's an example of a phase 2 single-arm study with Nivolumab and tremelimumab with concurrent radiotherapy in patients with basically immunologically cold colorectal cancer mets. Can we rev them up to get the immunotherapy to work? So the adverse event rate was 25% with an objective response rate that was lower than anticipated at 8.3%. Now this is for lesions that were not radiated. However, again, this may be worth it to the patient if you find the ones that have the 8.3%, because it tends to be a really nice response. So the real thing that we'll have to do is try to find out who those folks are so that we can sort of get through some of the administrative hurdles of trying to do these studies. Next slide. So ultimately, immunotherapy is amazing when it connects, and it rarely connects on its own. It's about 30% or less, and the really deep ones are about 5%. But it's well tolerated even when it doesn't. So a lot of folks say if we can try to improve the connection safely by adding an added local therapy, why not try to do it? And that's really cool because for the first time you have systemic therapy and local therapy that don't really have sort of a sequence or a lane that it has to stay in. They really overlap on that Boolean. Next slide. And, like Dr. He said, the FDA has recently opposed Nivolumab for HCC because there wasn't enough benefit for the overall population. But certainly we've seen patients who have had just Nivolumab as a standalone therapy that have had durable responses above 4 years. So really what patients are going to want to know is what is my chance of durable response, duration of response over how much is it going to affect my quality of life, or what's the adverse event rate? And I think that we're going to have too many oncologic or immunologic and pharmacologic permutations down the road to really stick with conventional trial design with, two competing forces on a Kaplan-Meier curve on a massive population scale. We're just way too personalized, and I think that's the way it should be going. Next slide. So it sounds like we're pretty much primed for some disruption, and it could be, any of the attendees or any of the people that are watching this video. You should be thinking about it because everyone gets trough mentality as they do this longer, and it's harder to come up with fresh thoughts. But this is absolutely, no pun intended, primed for disruption. And here's a picture of Marshall, the physician who discovered that H. pylori were responsible for ulcers. Before that used to be this huge skill set in doing selective vagotomies and Billroths. And he fixed everything with antibiotics by just thinking laterally. And I think that's probably what it's going to take to really sort of crack this code. Next slide. So in summary, interventional oncology and immuno-oncology, they are mutually exclusive and not mutually exclusive and likely synergistic. We're still defining best practice for local therapy and how to optimize immune modulation. Right now, we just try to do the best job that we can for what we know is there and hope that, with whatever we know we can use from in vitro data helps. And honestly, our best results come from reigniting the patient's own defense system. It's just really still complex to do. Next slide. And with that, I thank everyone for their attention.
Thank you so much, Dr. Toskich and Dr. He, for this amazing presentation. I personally learned a lot, as I'm sure everyone must have. And we will go ahead and take some questions at this point. And just a reminder to the participants, they can still type in any questions they might have. So our first question today is, what is the current status of the combination of immunotherapy and interventional radiology in practice?
Yeah, so that's a great question. And I just wanted to briefly mention that I think Dr. He has to go for another appointment. So if at any point in time she has to leave, I'm sure we'd all be happy to address written questions and respond later on.
I'll
So,
take this. Yeah. So the question is, what's the current practice for immune combination therapy?
Yes, Dr. He.
It's immune combination therapy. Both are okay. So currently, and we have moved from single agent to combination. So there are a couple of combinations. There are immunotherapy combination, such as CTLA-4 inhibitor plus PD-1 or PD-L1 inhibitor. And so that is the dual immune combination. We also use anti-VEGF plus immunotherapy. So VEGF is a very interesting growth factor. It's important for angiogenesis, and also the growth factor is a strong immunomodulator. It actually it has a lot of impact on the dendritic cells, which are antigen-presenting cells. So basically, when we use the anti-VEGF therapy, such as bevacizumab or TKI sorafenib or lenvatinib, and we'll basically kill two birds with one stone, because on one hand we worked on angiogenesis, second we use it as an immunomodulator. So the combination, at least it has showed very promising activity in melanoma, kidney cancer, and HCC, and will double the response rate by those combinations. And of course, additional immunotherapy combinations are being tested, such as we're using oncolytic virus plus immunotherapy, and we use other modality of immunotherapy in combination with immune checkpoint inhibitors. We currently also use IR therapy, ablation, try to use ablation to release tumor antigen, use radiation to release tumor antigen to see if that will promote the effect, increase the response rate of patients to single agent immunotherapy. I hope that has answered the question.
Right, definitely, Dr. He. That was great to. It was great to understand the mechanism of the combination therapy. The next question that we have is, what are the future aspects? What are the future aspects and current topics of research in the field?
You mean so what is the future direction, basically?
Yes, Dr. He.
Yeah. So and you can see with this whole discovery, actually the two scientists' discovery discovered PD-1, PD-L1 won Nobel Prize 2 years ago. And it's just changing how we're thinking about cancer treatment with this rapid breakthrough. So currently, and what there are 3-4 goals in the field. One is, how can we increase the percentage of patients respond to this therapy by doing combinations, by identify what is the mechanism of immune evasion in that specific patient. And that's one. Second is, as Dr. Toski has described the toxicities. Yes, so immune-mediated toxicities can be an issue. So currently, I think we're trying to identify combinations that will have better safety profile. And that sort of was a long way from interleukin-2, which has a lot of toxicity, to now PD-1, PD-L1, which is much better tolerated, and to additional therapy that have even better safety profile. The other thing is, these immunotherapies are very expensive, and with the infusion, because of the law, like the drug development, so it's quite expensive. So we're trying to identify biomarkers that will sort out the patients who will benefit from this therapy, and spare patients who will not respond to the current standard, and then so they can go get other therapy and spare them from any possible immune-mediated toxicities. So it's a very exciting field, and currently in cancer treatment. And I think it's also a perfect time to collaborate, such as like cross disciplinary collaboration, try to really maximize the treatment benefit in patients.
All right, thank you so much, Dr. He. That's great to know. The next question that we have is it more common to observe abscopal effects with Y90 cryoablation or any other localized modality?
So I don't think that someone can say it's more common for any of those, because you would need a certain number of events to exist for you to be able to power the difference between them. So that's how rare they are. So if you look at case reports, they've been described. I think that the true abscopal effect, where all of a sudden you have an activation that is, where otherwise you had no response, and now you do have a response, and has nothing to do with the local site in which local therapy was applied. I think that is truly going to remain rare. What I think people can focus on is the ability for sort of in-scopal effect, where you can say, all right, there are, as I had mentioned previously, some inherent liabilities to each therapy, whether if it's heat sink, if you're using thermal ablation, whether it's radiation watershed, whether it's ischemic reperfusion with things like TACE, all those avenues make it to where you would have something that otherwise would work pretty well for at least your local target that could be augmented with immune therapy. And I think that's one aspect where particularly it's applied to earlier to intermediate stage diseases, where you'll have the immune therapy be the adjuvant to the local therapy. And then you'll have probably avenues where you'll have the local therapy be an adjuvant to the immune therapy, and the immune therapy serves as a primary. So if you have more advanced stages of disease, you just need some inflammation, and you need some antigens to be released in otherwise what is a immunologically sequestered tumor. And that's where I think that we'll find that there is no one modality that is best. I can tell you right now, just out of the preclinical data, there's a lot of interest with cryo, there's a lot of interest with radiation, and there's a lot of interest with irreversible electroporation because of the ability to preserve native proteins more so than the coagulation that occurs with heat-based thermal ablation.
Right, that's very interesting, Dr. Toskich. Thank you so much for answering. We have another similar question. In your experience, which modality would be best to combine with immunomodulators?
Yeah, I think it depends on the tumor. So, I showed a picture earlier of an enormous right hepatic lobe vascular invasive HCC. If we wanted to perform cryoablation of that, that patient would be at high risk for something that we call cryoshock, which is where there are so many inflammatory mediators generated by it that the patient basically enters a septic type of shock through hyperinflammation. So that's not a safe thing to offer that patient, but a 300+ gray radiation lobectomy, which is what that patient got, was well tolerated. And so I think it depends on the phenotype of your tumor and how it's distributed. If you have something that's a solitary lesion, or it's in a difficult spot, or it has bad blood supply transarterially, that's fantastic for thermal ablation or external beam radiation therapy. If you have something that is involving a larger volume of disease, radioembolization has been able to very safely treat those as an outpatient. So I think it's going to be tailored to the phenotype of the tumor, not so much the single modality that comes out on top.
Right, Dr. Toskich. We have another question that I think was addressed in the presentation, but I'll just say it out. How common is it to use the combination of interventional radiology and interventional oncology in practice?
So in our practice, since about 2018, it's fairly common. And what we try to do, and it's difficult because there's not a lot of data, but it's still something that you do because you have your patient's best interest in mind, and you know what at least your local results are like. So when we see more aggressive tumors, for example, if I see something that looks like a more infiltrative HCC, for example, I mentioned that disrupted pseudocapsule, or have a high AFP, let's say it's 3,000 or 4,000. That's someone that we'll actually talk about getting immunotherapy, particularly if that person is is not bound for something like resection or transplant or off the bat. Obviously, it would have to be downstage to go to transplant. But I think we're seeing where we have coexisted so well in the same care plan for a patient that they tend to blend. So we see patients with more advanced liver tumors who are coming for local therapy as a boost, and we're seeing probably more intermediate stage or more aggressive looking solitary lesions in the liver that are going towards a boost. Now, notice how I've said the liver a whole lot. We have not really addressed this so much yet for things like metastatic renal cell or metastatic lung cancer, or metastatic melanoma, because a lot of those are currently going into trials. And so in general, it's good to respect. So if you have an institution that that's doing a trial and they're offering that treatment, it's important to support that. We are doing trials for primary liver cancer, which is why our experience is more within there. I'd like to ask Dr. He what her experience is in how you've seen the change in the co-utilization of these modalities.
So what in our center, what we have been doing is I think we incorporate liver target therapy for two purposes. And one is for major disease control. So I'm going to see a patient next Monday, for example, with a right lobe predominant tumor, large tumor. And there's also many smaller lesions and on the left lobe of the liver. So this patient, the large tumor, and there's no clear evidence of vascular invasion, but it may, if it progresses, it may cause vascular invasion. And then so we, in this case, I would ask our IR folks to see if patient would benefit from a Y90 treatment to control the predominant lesion. And then for the rest of the disease, I probably would do combination immunotherapy. And so one is for disease control. We've had cases with massive, with a large lobar Y90 or even a segmental Y90. And then patient actually has a very good rapid response to immunotherapy. Of course, those are anecdotal cases we have, but we have collaborated quite a bit with IR on those challenge cases.
All right, thank you so much, Dr. He and Dr. Toskich. We have a few more questions if you think that we still have some time to address them. If you would like, we can address them later, and I can email you those questions.
I'm fine. I believe Dr. Hay has to go to another meeting. Is that correct?
So I realized the meeting won't start at 5:30. So that's why I think we have a few minutes.
So we have time for a few more questions.
Right, thank you. So the next question we have is that, can we combine loco-regional therapy with chemotherapeutic agents other than immunotherapy?
Yes, I would have Dr. He chime in terms of what she thinks is up and coming that in that space.
So we actually use that approach quite a bit for other type like for example metastatic colorectal cancer, and because so HCC, for example, is not very chemosensitive, and we use this approach for metastatic colon cancer quite a bit, and also cholangiocarcinoma quite a bit, because those tumor are more sensitive to chemotherapy, and I do believe there's a role of local therapy, liver target therapy from IR on disease control in the liver. And the goal is to try to get those patients to resection. And so, and then in some patients, we can actually achieve long-term disease control and even put in a subset of patients in remission. Is how can we get this patient disease-free with surgery? And we do a lot of combination therapy, and so we treat patients with chemo and liver target therapy.
Yeah, so right, one of the exciting opportunities is that interventional radiology, by a side effect of being initially an entity that was meant to diagnose abnormalities related to blood supply, can increase the signal to noise for therapeutics. So whether it's through a blood vessel, or whether it's injected, or whether it's through intravasation, there is something that adds that extra edge that allows you to get closer to the tumor LD50 and reduce the systemic adverse event dose for pretty much any therapeutic when you sort of find, at least with the right approach, to have it delivered locally. So for example, we were talking about viral oncolytic agents. If you were just infusing through a peripheral IV, that's totally different than when you're trying to inject them locally within a tumor. So I think that in the same respects, hepatic arterial infusion therapy, which is done frequently in some centers for colorectal metastases, is another similar concept, where you have a high local dose of chemotherapy that by the time it enters a systemic volume of distribution, it is much more tolerable for patients, and they have a sort of an optimized intensity where it matters most. So I think, pretty much if there's local disease in the future, we should have a local engagement plan for that disease, in addition to a peripheral engagement plan, just like we were talking about compartments earlier.
All right, thank you so much, Dr. Toskich and Dr. He. The next question that we have over here is the combination therapy given to the patients in an outpatient setting or an inpatient setting?
So I think it depends on what the local therapy is. The vast majority of our thermal ablations and the vast majority of our radioembolizations are typically single session outpatient. So, there are some patients, if an extensive ischemic therapy like TAE or chemoembolization are performed, they may have some post-embolization syndrome. But I think with the change in approach, which is to deliver more peripheral and more selective treatments, even when performing things like TACE, that has led to more tolerable side effects for patients, to where it can be performed as an outpatient. And with respects to the systemic therapy, I'll have Dr. He chime in. But usually in our practice, unless you're having a melanoma treatment and having sort of a more vestigial IL-2 infusion, it is not something that has really required patients to stay overnight.
In terms of chemotherapy, most of the chemotherapy regimen are outpatient, and I think some sarcoma regimen, I think, or for most solid tumor regimens are outpatient regimens.
All right, Dr. He. And the last question that we have for today is, what should medical students and residents keep in mind?
Okay, I'm going to start. Well, I think you can see, even have been a practicing physician for many years, I've seen the change, sort of the landscape change right in front of our eyes. I do think for oncology, it's very important to get involved with research, and because that's the exciting, fun part. And then I think it's also a good for your career. Any sort of research, laboratory research, clinical research, and even patient-based research, and all those are important and then you can be part of this big advancement of cancer treatment. What else? I think this is what I was told by my many mentors when I was in training, is every week find a good science article to pick it up and read about and learn something new every other week. And I think that builds up, and then you can always stay sort of engaged in this huge advancement, this progress that's ongoing in the cancer world. That's my a few advices.
That's great advice. I I would say that it's obviously very important to heed with the words that Dr. He shared. You're not going to make an impact unless you go through the necessary rigor to investigate and defend your work. So that's not something that comes overnight, and it's something that ultimately at the end of the day should be enjoyable. I think those are the folks that enjoy it are the ones that tend to have, I think, the best results, particularly for their patients. So how to enjoy it? I think what's important is to remain remain playful. Don't be rigid, and don't be afraid to ask, why are we doing this way? And that's why I sort of made that slide in the beginning of my talk, but that is really true. The other thing too is you get experience in life outside of medicine, and take breaks to where you study something intensely, but then you go and you learn about life. It's very hard to protect your patient's life with the ferocity that's necessary unless you respect your own. And so take care of your health. And, I'm going to have more sort of the Hallmark card recommendations here, but it is true. And the people that I've seen do the best, including my mentors, were the ones that, would always respect those aspects of their life, because they were way more effective when they were taking care of patients. And that's, I think, this sort of last and most important thing is, don't ever be driven by a little micro obsession that you can create for yourself in what you created in your lab or in your petri dish. I think you have to remember ultimately what is the big thing here is that patients are given literally the most scary news that they'll ever receive about themselves when they receive this diagnosis. And when you're talking about things like cancers that typically require immunotherapy, they're not the ones that always have the most fantastic 5-year survivals. And so I think keeping your patients in mind, why are you doing this, and are you making a good impact, will make your patients happy, because you'll be aware of things that may not be that big of an issue to you or to your team, but it means the world to your patient, like trying to make sure you have workflows that respect quality of life. So with that, I'll seal things up on my end, but I do 100% think that ideas that are going to move this thing forward are going to come from folks that are very open-minded and lateral thinking, as opposed to something that we've been able to predict that we saw coming from 30 years ago.
Right, that's some great advice, Dr. Toskich and Dr. E. I'll definitely keep it in mind personally. I wanted to thank you again for taking out your time to teach us the basics of interventional radiology and immuno-oncology. Is there anything else that you want to cover before we end the session?
I want to thank you, thank Toski and also your team to invite me, invite the medical oncologist to talk with you guys. I had a great time try to think out of the box, think from our IOF folks' point of view, and I had a great time. Thank you for the invitation.
I'd like to thank Dr. He for coming and sharing her experience. I strongly recommend that as you mature in your careers, you reach out to your partners that are fighting this horrible disease and team up. It's way more enjoyable and the outcomes are better. You know, I also like to thank Dr. He for jumping in to help out with the slides, given the technical difficulties with the webinar software. And I'd like to thank the RFS, Suryansh, Tushar, and the SIR for the opportunity. This is really such a cool avenue and one that I wish that I had when I was training, and definitely grateful for the invitation.
Well, it was a pleasure having both of you today, and we learned a lot. And that's all we have for today. We would love to hear from all the participants and get your feedback. Thank you for joining us, and we will see you next at the next SIR-RFS webinar.
Thank you. Bye-bye.
Thank you.